Good morning. Finally, a day without rain until it rains tomorrow. So enjoy the day this afternoon and wear your sunscreen. I'm a melanoma NP, so I had to say that. Okay, so I'm going to talk about managing toxicities in the outpatient setting, and I'm going to try to present it in a more conceptual way with some examples kind of thrown in. And depending on how we're doing for time and interest, I do have a case that I just added that it's kind of a continuous case that if we don't get to it today, it will be in the link that you'll get. And I kind of was thinking out loud with it, so I actually put my thoughts on paper, which I know is a scary thing, but when you're home and if you want to kind of review that, if we don't get time today, then that may help kind of with the decision-making process as we go through various toxicities. So here are my disclosures. So the most important thing to kind of take home with regard to immune therapy, it's very different than chemotherapy, and we have to kind of get out of the mode of thinking of these therapies as chemotherapy, anti-neoplastic, killing cells. That's not how these agents work. The toxicity profile is all about the mechanism of action of these agents. So as the newer checkpoints are coming along, keep that in mind as we're combining them with other checkpoints or chemotherapies or other agents, because you really have to have a good foundational understanding of the mechanism of action of each one of the agents to know how it's going to look when you start combining these agents. So I implore upon you to really try to grasp the concept. So chemotherapy, as we know, the side effects of chemotherapy are related to the direct killing of not only cancer cells, but also normal cells. Immune therapies actually have no direct effect on the tumor. We're working through the immune system in an effort for the immune system to do what it's supposed to do. And so there is actually no direct killing, which is why we don't get the same side effects that we do with chemotherapy, like mucositis, hair loss, nausea, vomiting. Those things can happen, but the reasons they happen are different. So the spectrum of toxicity for immunotherapies is very different because it's affecting your immune cells. We have immune cells everywhere, in every organ, in every tissue. And so in theory, any organ or any tissue in the body could be affected. And what we see is a vast toxicity profile, and it's not uncommon to have more than one organ or system involved. In fact, when somebody develops an inflamed organ, let's say they have autoimmune hepatitis, you want to be looking for other inflamed organs as well. We regularly see patients present with both colitis and rash, or they'll have colitis, they get on steroids, and as they're tapering off the steroids, you then see the evolution of a hepatitis. So it kind of makes sense if you think about it, because we know that the immune system has received the message there's inflammation in one organ, so why wouldn't there be inflammation in another organ? So the approach is very different to how you're looking at your patients, how you're thinking about them, and I kind of use the term the lens. The lens that you're looking at when you're assessing your patients on immunotherapy is very different than chemotherapy, and I want to give a couple examples here. So traditionally, if a patient receiving kind of cytotoxic chemotherapy, as we think about it, develops a cough, well, part of the workup, of course, of what you're thinking about is, does this patient have an infection? So perhaps that patient would be started on antibiotics. Headache, let me go back. When thinking about patients receiving immune therapy, if they develop a new cough, we're not thinking infection, we're thinking, are their lungs inflamed? Is this an evolving pneumonitis? So I may want to get a chest x-ray or a chest CT. So I'm not thinking infection, I'm thinking inflammation. In my world, in the world of immune therapy, it's inflamed or inflammation until proven otherwise. And on your differential, your top two items on your differential should be inflammation or progressive disease or vice versa. So for a headache example, you may just tell your patient, okay, let's have you take some Tylenol or ibuprofen. But if a patient gets headache and immune therapy, is the pituitary gland inflamed? So I'm going to be thinking inflamed pituitary, apophysitis. Do I need to get endocrine labs to see if there is evidence of an evolving endocrinopathy? Do I need to get an MRI that's dedicated specifically to look at the pituitary? Because a standard MRI, the slices aren't thin enough to really look at the pituitary. So if you're thinking about this patient may have an inflamed pituitary, you want to make that known and you want to order a pituitary cut MRI or have it in the requisition to the radiologist so that they know to be specifically looking at the pituitary. Fatigue, well, I mean, we're all tired, right? But patients receiving chemotherapy are particularly tired, and you may talk to them about energy conservation, or maybe they're neutropenic, and so things kind of directly related to the reason that they are fatigued. But with immune therapy, it could be anything. But of course, one of the first things you want to think about is the thyroid inflamed? Is there a thyroiditis? So you may want to check thyroid function tests. Transaminitis, so these are just examples of different ways to be thinking about your patient receiving immune therapy. Now, dysphagia, which I have on the bottom, of course I left the best for last, is, well, patients have a sore throat, do they have a thrush or mucositis? But the differential for something as simple as a sore throat or difficulty swallowing is tremendous in immune therapy, because, believe it or not, something simple like difficulty swallowing could be the result of an inflamed cranial nerve. So is there some kind of neuromuscular toxicity happening? Is there some type of neuritis? And that can be indicative of myositis or myasthenia gravis or something like that. So we may need to go down that way when diagnosing these patients. The most common adverse events are listed here, and it's a little challenging to probably see up here, but the darker colors, actually in this slide, the darker colors at the bottom are your higher grade toxicity. So this is just a profile of the most common adverse events with all of the checkpoints. So the anti-CTLA-4, anti-PD-1, and then combination of CTLA-4 and PD-1. So in my world of melanoma, combination Ipi-Nivo is approved, and it's first line for many of our patients. So we give a lot of Ipi-Nivo. And again, we give Ipi-3, Nivo-1, so our doses of ipilimumab are higher than most of the other malignancies. And we know that ipilimumab toxicities are dose dependent. So the more Ipi a patient has received in their life, the greater likelihood there is of a more high grade toxicity. That's not true with the PD-1s. So what we see here, as you can imagine here, with Ipi-Nivo, we know that that's a toxic combination. So your blue lines here are the toxicities associated with combination PD-1 and anti-CTLA-4, much more prevalent in the patient population receiving both. We're going to expect them to have more toxicities. So if I look at the less common but somewhat notable, so the ones you kind of want to pay attention to, that may not be common, but the ones that you don't want to miss are seen here. And if you look here, hyperthyroid, hypophysitis, hypothyroid, and pneumonitis, I kind of just described that in the last slide. We see a lot of endocrinopathies when you're combining, and by endocrinopathies I mean the inflammation of the various organs in the endocrine system. But we see a lot of thyroid dysfunction. So for patients receiving combination or even just single agent PD-1, I would argue that the numbers are as high as 40 to 50%, if not higher. That's not something you want to miss, because those patients can really feel awful if they're hypothyroid. So if you can pick that up early, you'll do them a lot of favors. And also, as challenging as immunotherapies can be, they are relatively predictable. Most toxicities, if they're going to occur, will occur within 3 months of starting therapy. Now, I say most because, of course, there's always outliers. But if you look at this schema here, the red line indicates about 7.5 to 8 weeks. All of the side effects, essentially with the exception of pulmonary, which we tend to see a little bit later, and renal, which happens later, so nephritis tends to happen later, they all happen within 3 months of therapy, of starting therapy. So that's when you want to be really vigilant about paying attention to those labs, paying attention to what the patient's baseline lab is, and you may want to document. In my notes, when I am writing a note for each patient, I have their baseline creatinine that was identified before they started therapy. Because one of the things we've noticed is we've missed a couple of cases of nephritis because it's been normal. So if a patient starts with a creatinine of 0.6 and it doubles to 1.2, well, that's not really that big of a deal, right? But it's doubled since the patient has started on therapy. So that could be a subtle sign that something's evolving. So even though labs are normal, you're looking for change from baseline. So I tend to document the creatinines because a lot of people, we tend to think, oh, the patient's just dehydrated, we'll give them fluid. But the reality is we could be missing an evolving nephritis. In general, though, monotherapy is very well tolerated. As scary as it is to hear about all these toxicities we're discussing and these life-threatening toxicities, and you're going to hear Carrie talk about all the bad things, most patients do really well on single-agent PD-1. It's very well tolerated. It's almost too good to be true. There are patients that don't have any side effects at all. They may be a little tired or they're bothered, and after a while, they just don't want to come in every couple of weeks. That's the biggest issue. It's very well tolerated for the most part, but you have to maintain vigilance. When you start combining, that's when we start to really think we got to pay attention a little bit more. So combination is less well tolerated. This slide here shows the incidence of, the combination Nivo-Ipi, Nivo-Ipi, and Pembro. So the three PD-1s, and then the combination. And so in general, pretty well tolerated. What I do want you to pay attention to is, again, the combination. If you look here, so grade 3 or 4 toxicities, we consider those high-grade toxicities. Those are the ones that in the clinical trials get identified and really described, because if an agent has a very high grade 3 or 4 toxicity profile, you worry about it actually being tolerated in the kind of everyday world outside of clinical trials. And so if you notice here that most of the grade 3 and 4s, compared to essentially nothing here, you're definitely much more prevalent in the combination therapy. So how many in the audience have given or give Ipi-Nivo or combination checkpoints? In your experience, has it been tolerable, toxic? How many have had something go really bad with some patients? And how many in general you were surprised that, oh, things went so well, I don't know why everybody's all hyped up about this? Yeah, Ed, I don't think so. So again, I'm just highlighting here the combination Ipi-Nivo. I will point out a 56% grade 3 or 4 toxicities reported in the 067 trial. So more than half of the patients that go on the trial or went on the trial, half of the patients that we see in clinic that are going to get combination are likely to have a grade 3 or 4 toxicity, which means hospitalization or high-dose steroids. So when we see these patients and we're counseling them about what they're getting themselves into, so to speak, we talk about this. We talk about the very high risk, the reason we see them weekly, the need for open and ongoing communication on a regular basis, and the likelihood of admission. On the other hand, when they come in and they're doing great, they just get annoyed that they have to keep coming in and they're doing great because they don't know what we're talking about. But it's so unpredictable that we have to be prepared for kind of anything to go wrong. But the reality is that patients may do very, very well. The most common cause of death that we saw in the trials was related to colonic perforation. So you hear a lot of hype about colitis, and there's providers that I've heard in the community that don't want to take on combination therapies because they're very concerned about the colitis issue. The reason we're doing it, in the data sets that I don't have up here, all those Kaplan-Meier's we saw yesterday, Justine Cohen did a great job showing all those. These can really work for so many patients. And so many patients now are in our clinic and have had such prolonged survival, or at least stabilization of their disease, that we take the risk and we go ahead and do this because for many people, they're getting ongoing durable responses and they're having an incredible quality of life. And in the world of melanoma, we never had that before. So that's why we're kind of willing to undertake these toxicities. So how do we manage them? What's the way that we can handle things in the clinic? Most important is that management is going to be based on the severity of the symptom. So in order to know how severe it is, you have to know what the patient's baseline is. So I've learned more than I ever wanted to know about bowel since we started giving a lot of Ipi-Nivo, and we talk about it all the time, and we really need to document. There are patients that can come in and it's normal for them to have 3 to 5 bowel movements a day. And then there's people that will come in and they go every other day. So if I see a patient in clinic, maybe I don't know them, I'm seeing them for a colleague, and they say, I've had 8 stools today. Well, is their baseline 0 and now they're going 8, which makes it a grade 2 to 3? Or they go sometimes 5 times a day, and now it's 8 times a day, so that's only a difference of 3, which would make it a grade 1. So you have to know the baseline, and it's really helpful if you document it, because with the immune therapies, you need to know what the change is from baseline. And so you need to identify and document what the baseline is. There are checklists that are available. There are lots of guidelines that are available about how to assess what to be looking at when you're meeting and seeing these patients for the first time. And the kind of strategy that we use for managing these patients is early identification. I can't emphasize enough how much education is important. Patients and caregivers, but also colleagues. We can't know it all, and the way things are so specialized now, we need to be able to depend on each other, which is probably why you're here today, to learn how to manage these. The standard mantra now is that corticosteroids it's okay to start them early. If you are concerned about somebody that there is a persistent toxicity, there's always been this concern about giving the steroids. People don't want to do that. But what we've learned now is that steroids really do not negatively impact treatment. So in other words, if somebody requires high-dose steroids, it's not going to minimize their anti-cancer effect from the treatment. Of course, there is one exception, but I'm not going to go into that. And a multidisciplinary approach is absolutely critical. We can't do this. We can't know about every system, which is what I said earlier, is that any system can be inflamed. So we need our colleagues in the various disciplines to be able to help us think through these difficult and very complex cases. So how do we figure out what the grade is? So for those of us that do clinical research, we know how to grade things. There's this thing called a common toxicity criteria that we need a way to objectify a patient's subjective symptom. It's easy when their labs are abnormal because there's standard guides that we have, standard recipes. But if I call Carrie and say, I'm tired, and she says, I'm tired too. Well, she's got a newborn, I don't, so I don't really have an excuse. So she has like real fatigue, so maybe grade 3. But I think mine's just as bad as hers because I have 14-year-old twins that are obnoxious and I'm up all night with them. So how do you kind of differentiate? So we need a way to be able to objectify that. So there's actually these guides, and I would encourage you to look at the common toxicity criteria if you haven't seen it, because it grades things for you. Grade 1 is mild, asymptomatic. Grade 2, grade 3, grade 4. Grade 5 is death related to an adverse event, so from that drug. And it really kind of lays it out for you. So if I do call Carrie and say, I have a grade 1 fatigue, she'll know what I mean. But if she says, Krista, I have a grade 4 fatigue today, I know that we need to get some help for her to see patients because I know what grade 4 means. So when we're grading things, that's what we use when we are writing notes, when we're trying to figure out how severe somebody's side effect is. And it's really important for things like diarrhea. So it's literally how many stools per day. Nephritis, there are guidelines based on numbers. Pneumonitis, it's based on symptoms and what the radiologic imaging looks like. But in general, the kind of criteria is your stoplight kind of algorithm that we use here, where grade 1, things are pretty mild, we're going to watch them, patient may be asymptomatic, they're safe. Grade 2, all right, now we have to start thinking about, is this an inflammation that's going to continue to progress? And then, of course, grade 3 and 4, we're worried. We need to really be intervening and thinking about these. So as a general rule, most of the early grade toxicities are able to be managed in the outpatient setting. The high grades need to be under close observation because, again, what I said earlier is if you have one inflamed organ, then it's very possible you could be having other inflamed organs evolving. Management for mild is to manage symptoms conservatively. Persistent mild or moderate, you're going to step it up a bit. So if somebody has a little bit of a rash maybe on their knee or their ankle, they come in a week later and now it's kind of all over their body and it's starting to maybe go in their ears or their mouth. Well, something's happening. So we really need to intervene and do something, or it's like a ball at the top of a hill. It's just going to keep rolling and picking up speed. So you need to stop, you need to intervene and kind of reel back in that immune system. So we typically will start with oral corticosteroids at a dose of around 0.5 to 1 milligram per kilogram per day. And if that's progressing, or if the toxicity based on the grading system in the book that I just showed you, if it's progressive or it is severe, they need to be in the hospital or at least in the clinic every day being seen with usually IV steroids initiated. There are algorithms that will help guide you through this. You don't have to figure this out on your own. There's so many resources available. But I will say that sometimes steroids are just not enough. If you can't control that immune system and you can't reel it in, we often have to go to a second-line immunosuppressive. And we've learned now that we don't want to be waiting. We don't want somebody on steroids for 2 to 3 weeks before we're adding in that second-line immunosuppressive, because if the steroids aren't working relatively quickly, they're not going to work. And so to let a patient kind of just hang out with 100 milligrams of prednisone is really not gonna do it anymore. Unlike chemotherapy, we do not reduce doses. If you are kind of setting off somebody's immune system, even if you give them a quarter of a dose, it's just going to contribute. So unlike chemotherapy, we do not dose reduce. Our mainstay is to withhold doses or omit them. And again, if a patient has an immune toxicity evolving, well, it's because their immune system has received the message. We know that the message, those brakes are off, so maybe they don't need that additional dose. So the safest thing to do is kind of take a time out and regroup, and you don't necessarily want to go ahead with the agent if you're unsure. And this is the most challenging for patients because they think, oh my gosh, if I don't get my treatment today, then what does that mean? So they struggle with this. But if I'm ever on the cusp and I'm in clinic, I will say, you know what, we're going to regroup. We're not going to give you the treatment today. Let's see what happens over the next day or 2 or 3, and then we can reevaluate. You can always bump out their treatment or delay it by a week. So the last thing we want to do is give more drug that day if there is something evolving, because essentially you're just going to contribute to it. And this is the little pearl of what I had before. I said a minute ago, patients who will benefit from corticosteroids usually do so within a couple of days, not weeks, a couple of days. If symptoms do not improve, particularly after about 3 days, if they're on IV steroids, you need to step it up. They need a second-line immunosuppressive. And I see you nodding your head, Carrie, because I think that's a lesson that we've learned in the last number of years. Okay, so what happens if a patient does develop a toxicity? You've decided to hold their therapy, things have resolved, or they've had a serious, like a grade 3 or 4 toxicity, they've required high doses of steroids, they're now back to their baseline, off of their steroids. What do? Can you give them another dose? And so the question of re-challenge has been a huge issue, but the reality is, yes, in some instances you can re-challenge. So when would you do that? Typically, for let's say the lower grade, let's say somebody is miserable because they have a grade 1 or 2 rash, itchy rash, that's a reason to hold. So for many of these patients, if they require steroids, we'll let things settle down, let their skin improve, and if they're feeling better and they feel like they're back to their baseline, you could start again. You're going to have a very high vigilance for paying attention and counsel the patient that if they were to get itchy again or if a rash were to evolve, you have a plan in place, because it may happen again, but it doesn't always happen. But typically we will re-challenge when patients' toxicity is back to grade 1. If they've been on steroids, we want them under 10 milligrams, or some will argue 7.5. And then interestingly, importantly, for the endocrinopathies, we no longer hold. We feel that if the endocrinopathy has been identified, they're on the appropriate hormone. Let's say they've been diagnosed with a hypothyroidism and they're on their thyroid hormone now, we will continue to treat, because that issue is being addressed. They're on the appropriate hormone, and we know that we can control it through labs and just following them, imaging or whatever. So endocrinopathies, it's also in the guidelines that is the one toxicity that is safe to continue to treat if appropriate clinically. There are some situations where you may not want to treat through if you're unsure of what's going on with a particular patient. But as a general rule, for a safe patient in the experienced hands of a clinician that knows this, it's totally fine to continue treating through. And that I mentioned this earlier, that we do know that steroids do not necessarily have a negative impact on the treatment. In other words, you can give them steroids without having to worry about an anti-tumor negating effect. And we know that from the clinical trials. We feel very comfortable with that. And I try to describe to the patients that we're just trying to kind of reel in your immune system again, but it's working. We know that the treatment, at least to some degree, we know that the immune system has the message, so it's okay to treat on steroids. Now, if a patient's having a high-grade toxicity and they're on 80 of prednisone, doesn't make sense to restart the therapy, right? So we really want them back as close to their immune status of normal as baseline to restart. And then kind of in theoretical thinking, you're not going to want to give an immune agent if somebody's on high doses of steroids, right? It's kind of counterproductive there. So we want them on 10 milligrams or under or equivalent of their prednisone or other. So treatment consideration. So this is something that's kind of come up more recently, and I'm switching gears a little bit to just talk about what are the other things in the everyday clinic that we want to be considering when we're seeing these patients. And this has really been kind of trial by error that we've learned, and then there's also now been more evolving data that has really made us begin to think about our practice. So we've heard a lot about the microbiome and how important it is for patients on immune therapy. And of course, all patients with cancer, or at least most of mine, maybe it's just my practice, they're always asking you, what can they do? Should they be taking probiotics? Are there vitamins they can take? What about CBD oil? Like all of these other kind of things that they want to be doing to complement their treatment. They're probably doing it anyways. They're just not telling you if you encourage them not to, because they hear it or read it on the internet. And Dr. Google always advises things differently than we do. So patients often have these complementary therapies that they're doing. But it's important now to really get a true sense of what's happening, because we've learned that changing the microbiome may actually change the response now to immune therapy. There are, and I don't have this data specifically in here on purpose, but there are specific gut bacteria that are associated with more favorable prognoses for patients receiving immune therapy. And so if you start altering the gut by high doses of probiotics or various things that are going to change your stomach gut, then it changes potentially the response to immune therapy. So hearing all this, we've now kind of changed our practice in the sense of if patients aren't on probiotics to begin with, we encourage them not to be on probiotics, not to start. We try to minimize the use of antibiotics at this point. There's some literature coming out that use of antibiotics may negatively impact the effect of immunotherapy. So if I have a patient that maybe is going in for, I don't know, a dental procedure, and they require, or there's a potential for infection and they're going to require antibiotics, I will actually now ask them to delay it, and maybe they could have it done later. So normally on immune therapy, it's no problem going to the dentist. It's no problem having these kind of procedures done. But if they are going to potentially require antibiotics, I don't want to do that now because it's going to change the gut flora, potentially put them at risk for C. diff. And so these are the kinds of things that are changing a bit in practice now. Same is true with proton pump inhibitors. There's also literature suggesting that that can alter the gut microenvironment, and maybe we don't want to be doing that. Now, of course, so many cancer patients need these PPIs frequently. And if somebody's on high doses of steroids, of course, they may need to be on that. But really take a look at your patient's medication list. And half of them, I'll tell you, why are you on the PPI? I don't know, I've been on it for like 10 years. I think my primary care put me on it. I don't know why I'm on it. Okay, so they probably don't need to be on it. So we're really being thoughtful, looking at these medicines, trying to take them off of it and counseling them so that they understand why maybe we don't want to be influencing the gut bacteria anymore. So in our practice, we've really been paying attention to these and trying to take away any unnecessary medications that patients may have. And it actually includes, there's data now suggesting that there may be a negative impact of CBD oil with immune therapy. This was recently published about a month or so ago. So we don't have enough data to actually be making a call or counseling patients, but it's something in the back of our minds as clinicians we're really paying attention to and trying to get a good history now, more so than we ever did, of what patients are doing in terms of CBD and the various different marijuana products. And so the other area that, this is kind of my thing that I am very passionate about, is this whole area of triage. Maybe because I'm a nurse practitioner, mid-level provider, we often are asked to be the ones taking these urgent calls. And I see some colleagues nodding in the audience here, my nurse practitioner and PA colleagues, that it's incredibly challenging to be able to triage immunotherapy. And what's concerning to me is that there's often practices where they have one of the chemotherapy nurses taking the triage calls. Those nurses need to be educated about how to triage for immunotherapy. There is no standard guideline right now for how to triage phone calls for immunotherapy. The questions that we need to ask patients are very different than chemotherapy questions. So if you have a patient that calls in and says, oh, I'm getting chemotherapy and I have diarrhea, well, what's the nurse on the other end of the phone going to counsel them appropriately how to manage diarrhea with chemotherapy? But what if the patient just calls their Ipi/Nivo chemotherapy and they're calling in with diarrhea? I mean, that's a huge difference. There's no guidelines. The Oncology Nursing Society is desperately working on this. ASCO, ACR, none of them. There are no guidelines yet on triage. So this is something that, as a practice, our practice nurses, essentially all they do is triage these phone calls and do it really well because they know what to ask for and know what to look for. But I think this is a huge responsibility in private practices or in practices where it's the same nurses doing the phone calls in the chemotherapy administration or medication administration, that there has to be some sort of training so that they are counseled and can educate appropriately. For some patients, especially going into a weekend, if I'm not really sure who's on call for that weekend, I will actually write down on a piece of paper what to tell them when they call in. I am on Ipi/Nivo. I have diarrhea. Krista told me that this is a red flag. Just so that the person on the other end of the phone, I don't know how much experience the on-call person has with Ipi/Nivo or other immunotherapies, and so we don't want them to get into a situation where the clinician on the other end of the phone, if they're told that their patient is getting chemotherapy and they're having diarrhea, well, they're going to triage appropriately. But they'll triage differently if it's immunotherapy, and that's another area. And the other aspect is with all of these new therapies that are out in the clinic, how do we handle the influx of urgent visits when a patient is calling in with a toxicity complaint and they need to be seen that same day? There are some toxicities or some complaints that we don't even want to wait 24 hours. They need to come in, they need to be assessed, they need to do that now. Well, we're all busy enough in our everyday practice, so who's going to be able to see these patients and how are you going to get them in? So triage is a very big area, and a nurse practitioner colleague and I actually just published on this last month, and it was really just meeting the challenges of formal telephone triage and asking administration to kind of pay attention to this in different centers, because this needs to come from above, because immunotherapy, as we've heard from the last day and we'll hear later, is not going away. It's just going to become more complex. So we need a strong foundation for those clinicians that are on the other end of the phone. There's tons of resources available. We have 4 major groups that have published very recently. These are all available in public domain. They're all different, and they all triage a little bit differently or have guidelines that are a little bit different, but they're tremendous resources that I would encourage every practice to have available. They've all been developed by experts in the area of immunotherapy. The CTCIE, so the Common Toxicity Criteria for Adverse Events, their melanoma group is spearheading this nationally, but we are looking to develop a specific criteria for immunotoxicity, because if you look now in the current guidelines or in the current CTCIE, if you look up, say, endocrinopathies, it's not very specific. So we're trying to really kind of zone in on the toxicities that are associated with immune therapies and have it as their own thing. ASCO has guidelines, NCCN has guidelines, they're, again, all available. SITC has guidelines, SITC has lots of working groups. So SITC is the Society of Immunotherapy and Cancer. It's a tremendous resource. I'll show you here that they just have a book out as of 4 weeks ago. I haven't seen it yet, but it's supposed to be fabulous. And it's all about how to manage immunotherapy toxicity, written by experts in the field. So that may be something that people are interested in and having it in their practice. And so there's certainly an understanding and a definite need to educate ourselves, our patients, caregivers. Just how we go about operationalizing this is a question. Different centers across the country, including ours here at MGH, under the direction of Carrie, who's done an amazing job pulling together what we call our SICK team, which you'll hear about, our severe immunotherapy complications group, and they are a consultant service for the inpatient side. I'd love to see something on the outpatient side as well, have kind of physician and advanced practice champions that can help our colleagues be able to assess these toxicities in the outpatient side, and then kind of have community involvement as well. So this is something that is going to continue to evolve, and it's an area that we desperately need our colleagues from community centers in practices of all sizes to kind of really buy into and be able to feel comfortable managing these patients in the outpatient setting. So I think I'm going to end here. I'm not going to cover the cases because you will have the link, like I said, and I really kind of outlined all of the cases. I'm happy to discuss later, and we're going to have a panel in a little bit, and Carrie is going to move into the next part of it. But I think it's something to really pay attention to, and if you're in a center or a facility that you may have a role in being able to kind of formalize a toxicity assessment program or policy, I would love to hear about it, and I think it's something that we need to really formalize as we move forward, because patients are the ones that really benefit from clinician expertise. And when I hear stories of a patient, something didn't go right because the clinician wasn't really comfortable managing that toxicity, that doesn't feel right. So I think as advanced practice nurses and PAs, this is an area that we can really excel and really kind of take this on. And I'm going to end there. So. I don't know how to get out.
Questions?
Try to get out of this.
Oh, here we go. Questions? Maybe I'll start. So, Krista, you had one of your earliest slides. You had chemotherapy on one end, immunotherapy on the other end. How do we manage when we're combining the two? Mm-hmm. In melanoma, we're not really doing that yet, but in lung cancer, we're doing it for
right.
2/3 of patients. And I'd say it is hard. It is hard. You see LFTs go up, but the chemo does that in most people. Right. So how do we have to adapt in those situations?
So it's a huge question, and I think this is really where we know that most clinicians know chemotherapy toxicity. You just said it. We know that happens with LFTs. But if there's uncertainty with what the effects of the immune therapy is, it makes it more difficult. So if you know both immune therapy and chemotherapy, but then you have to know what the combination looks like, we don't always know. And I think what we've learned in melanoma, and I presume in lung and other areas using chemo, is we manage things a lot different. We're less inclined to say, let's just push, and instead take a time out and say, let's be thoughtful about this because we don't know what these combinations are doing, and be more inclined to hold doses. Is that what your practice may entail?
It is, and I find that we rely a lot on probabilities.
Right. Right.
So,
right.
Pemetrexed, most of the time it's that's causing the LFTs to go up, or there's a 1% to 2% chance this is the pembro that we're giving with it. I find myself checking labs more. Mm-hmm. Have you come back in a week and let's just do another interim tox check. But I do think this is some place where we're also going to have to think about, and you were hinting at it, things like telehealth and other things rather than always bringing people into clinic. I think we're going to have to think about the changing places of care too.
And really paying attention to medications and looking at them. Are there a lot of medications that a patient's on that are metabolized through the liver? Can we look at those and just make thoughtful changes that may take away some of that uncertainty?
More questions? Yep.
I just wanted to add to answering that question. I do think that because at Massachusetts General Hospital and some other hospitals, we're being so aggressive with the research that we're doing in the biopsies, I'm hoping that there will be certain patterns of these immune-related adverse events that we can recognize so that we might be able to tell what is the pattern of LFTs with patients who are getting hepatitis on the chemo versus the immunotherapy, or patterns of colitis. We hopefully will be able to do enough research to be able to distinguish what is causing the immune-related or the adverse effect. Is it from chemo? But I think we are going to see, and we do see it in melanoma because we combine targeted therapies and immunotherapies. So I do think it's a major question, and hopefully research will help us with that.
And I think your point is good in the fact of getting biopsies, because maybe a liver tissue is going to look different when it's inflamed from immune therapy versus immune therapy plus chemotherapy. So those types of patterns are very helpful.
As you know, there are a lot of toxicity with immunotherapy, and there are lots of publication about the gut bacteria and the ketogenic diet. Do you think that is there a chance that we can combine with gut bacteria therapy and the ketogenic therapy? Thank you. Perhaps these two therapies has lead to toxicity, and then will enhance the immunotherapy.
I didn't hear the last part of that. I heard up into
about the ketogenic diet. Ketogenic diet. Yes.
I don't have an answer for you. So the question was, what is the role essentially of a ketogenic diet in terms of altering the gut bacteria? Is it beneficial or detrimental? Is that correct? And we have zero data on that. I will say that the Israelis are very advanced in this area, where they are doing fecal transplants from patients who've had great outcomes with PD-1, and they're taking their fecal material and transplanting it into patients that have progressed on agents to see if they can alter the gut so that it may induce a favorable environment. And they are experimenting with some various types of diets, but that really needs to be a very controlled, very regimented trial to look at that.
Other questions?
Just one question. If we use a combination of immunotherapy and a TKI, and we have a severe case of diarrhea, what is the first therapeutic approach in this situation? Do you prescribe corticosteroids and loperamide, or?
So the question was, what happens when we combine immunotherapies and TKIs? So there is kind of no standard regimen to be doing that, but we do it fairly regularly under controlled settings. It's extremely challenging because we think that the synergy is going to look even different than one or the other, and the risk is much greater for bowel perforation if you add TKIs into the inflammation from immune therapies. So we proceed very, very carefully with that. We would probably stop the TKI. We would also hold the immune therapy, see what happens. We are very aggressive with doing bowel or colon biopsies so that we know exactly what it looks like under the microscope, and we will gear our treatment based on the pathology under the microscope. And sometimes we can tell, is it the checkpoint or is it the TKI?
I have one more question. I work on the inpatient side, and we'll get people from clinic who are admitted to us with various complications. They're trying to determine if it's from the immune therapy. And I feel like in the last couple of years, there's been this sort of clinical practice of avoiding steroids, but now it seems like that's shifting. What's prompting that shift? Is it just that we have more data? I think, at least on my practice, as I'm hearing this, I'm thinking, gosh, we need to really get with the program of recognizing early treatment to avoid further issues down the line.
So that's a great question, and the question is why all of a sudden is it okay to use steroids when it never was before? So I can answer that from a melanoma and kidney cancer perspective because I used to be an interleukin-2 nurse way back when. Melanoma and kidney cancer in particular are very immunogenic cancers, and immune therapies were primarily the only effective treatment, and it was very low response rates. We used to use interleukin-2 all the time. There was an absolute contraindication to use steroids for the cytokines because we know that there is an effect on cytokines when you're using those as treatment that is different than checkpoints. So when the phase 1 clinical trials were happening with MDX-1101, which became ipilimumab, we did not use steroids and people were dying. And so then they learned, well, we have to give steroids to rescue these immune systems, and patients were doing okay. So we learned that it is okay to give steroids, and now we have a lot of literature supporting that. And so it is now the standard. We need to control these immune systems, and steroids are the first line. So it's okay to give them. We like to wait until at least the first set of scans to know what the response is, but we have to use steroids to rescue these patients.
And Krista, do you distinguish steroids before you start immunotherapy versus the addition of steroids once you've already started?
So that's a great point. We do not want patients on steroids before they start. So for example, we don't pre-medicate patients with steroids to give these agents. There's no reason for that. But also we want their immune system, to use a visual, like we want their immune system as even as possible. If you give steroids before they've had their immune therapy, you're going to suppress their immune system. And then to have an immune effect, it's going to have to just go this much higher. So when patients have a toxicity, it's because their immune system's up here. Steroids are just going to bring it back to where it was. So we're not trying to suppress the immune system, we're trying to just kind of get it in check. But we don't want to start them out on steroids. We don't want them behind the 8 ball, so to speak. And so we want them as close to homeostasis as possible in terms of their immune state. Now, there are patients that may have brain mets or may need to be on steroids for chronic illness for whatever reason. If they're on physiologic doses of steroids, then that's fine because that's not on steroids. But if they're on high doses of steroids for whatever reason, then we really have to be thoughtful about what are we gaining by starting the immune therapy at that point. Make sense?
Great, thanks so much.